Hi, pulmonary people. This is Dr. Lisa Kopas coming to you from the Texas Medical Center in Houston, Texas. I am a general pulmonologist and advanced bronchoscopist with pulmonary critical care and sleep medicine consultants, also known as PCCS. So I'm here today to talk to you about the 5 top new bronchoscopy technologies. Number 1, we'll talk about robotic-assisted bronchoscopy, especially in the ion system. Number 2, bronchoscopic lung volume reduction, also known as valves. Number 3, cryobiopsy, and where are we with that now? Number 4, ultrasound and other advanced intraprocedural imaging. And then what's in the works? We have Resolve trial and also the burgeoning Aprio implants. Okay, so we're on to the ion system. So I think everybody's heard about robotic surgeries. They're in all types of surgeries nowadays. But we have recently been able to partake of that technology with our robotic navigation bronchoscopy system. So these are mostly used for small peripheral lesions which would not have been reachable before with a standard bronchoscopy. So as you can see, the patient lays here on a typical operating bed, and the bronchoscopy is actually moved by a robot arm. Now, the bronchoscopist stands away from the patient, looking at a screen, and toggles and moves the scope using a roller ball and a spin ball. Okay, so you can go out virtually and look at the pictures and see where you're going based on your CT scan plan. And what this has done for us is it's made peripheral lesion tissue sampling for cancers or other types of pathologies much more accurate. The robotic arm can hold and turn and make very fine movements much better than we can with standard bronchoscopy. It can also, as it's smaller, get out to the periphery of the lung, almost out to the pleura. And then lastly, we can better control and utilize the scope using advanced imaging such as cone beam CT or CEOS 3D resolution fluoroscopy. So all in all, that makes our yield up to 90% now. Quite an improvement. All right, so we'll talk about number 2, bronchoscopic lung volume reduction. This is a technology to reduce air trapping in the disease of emphysema. We have been able to do that surgically by taking out 1 or 2 lobes at a time, but that presents with a lot of morbidity and mortality problems. So the holy grail of the treatment of emphysema is how do we do the same thing as surgical lung volume reduction without all the trauma? And here we go. We can use a standard scope, as you can see here, drive out a catheter, insert one-way valves into the lobe in question. These valves, as you can see, do not let air pass into that lobe, but allows all air and secretions to come out. Over a short period of time, that lobe will deflate or cause atelectasis in order to give the better parts of the lung literally more breathing room. It also causes the diaphragm to come up in its natural position, making all movements in the lung easier and more comfortable for the patient. There is quite an improvement in most patients with this procedure. They are able to walk farther, do more, and breathe easier. Okay, what about cryobiopsy? So cryobiopsy is like the famous Christmas movie. You put your tongue on a frozen flagpole and it sticks. So cryo has been used in central airway lesions for quite some time, but in the recent past, we've utilized it now for interstitial lung biopsy and tissue sampling. it gives very nice samples between 5 and 10 millimeters in size, which is much more than you can get with a standard forceps biopsy. We have in the past gotten biopsies for interstitial lung disease with open lung procedures. However, there's a lot of morbidity and mortality with those procedures, much more than we have with cryobiopsy. Now, it doesn't mean that cryobiopsy is without any adverse events. I would recommend sending your patients, if you are going to have cryobiopsy done on them, to a center that does a large volume of them. In my operating room, we have checklists and protocols so that we can minimize adverse events such as bleeding and pneumothorax. All right, then there's the new mini probe. Irby has made a new mini probe 1.1 millimeter in diameter for use in bronchoscopic procedures. I use that particular probe mostly for EBUS procedures. So with EBUS, as we'll talk about in a minute, there's a ultrasound that allows you to real-time sample, needle sample lymph nodes in the mediastinum, mainly for cancer staging. With the mini probe, you can actually get histologic samples that are much bigger than the typical needle cytology samples. So that's a great improvement. Also, the mini probe fits down the ion, and you can get really nice samples from the periphery of the lung as well. Then there's ultrasound and other imaging, but I'll mostly talk about ultrasound. The standard EBUS, as I discussed before, will be used for cancer staging, trying to sample all the lymph nodes that we can reach with our ultrasound scope. And the linear ultrasound does have real-time sampling visualization. So as you're watching the needle go into the lymph node, it's right there on your screen. So there's very little risk of any type of adverse events or complications. There is a radial probe, but it does not have a needle attached to it. So you can't actually sample real time while you're visualizing. So in that case, you would put the probe in there mainly just to get an idea of whether your catheter is in the correct peripheral space in order to sample peripheral lesions mainly. The newest advancement in bronchoscopic ultrasound is called the iNOD, and it fits through a flexible scope or an ion. And as you can see here, it has two parts. One is the small ultrasound, and then you have this needle going out to the side where you can watch your sampling real time. And what's in development? Well, we have rheoplasty. Rheoplasty is a pulsed electric field technology that is applied serially to every airway that is reachable. It is a part of the RESOLVE trial. That is a trial that's undergoing currently for the treatment of chronic bronchitis and COPD with exacerbations using this pulsed electric field technology in order to ablate or diminish goblet cells in the airways. These goblet cells are what produce mucus in the airways, and that is quite a problem in patients who have COPD of the chronic bronchitis variety. So we'll see how that ends up with their particular data. They're also starting to use it for local cancer ablation. So that's very new, and we'll see what they do with that. Next on the list is the Aprio implant. That is a new technology for the treatment of emphysema, similar to the valves that we talked about earlier, where you would deflate a part of the lung in order to remove the air trapping and the room that takes up. In this case, you would actually insert this implant that gives an escape valve to the air so that it comes out. It is pending a U.S. trial. There has been some patients that have been done outside of the U.S., and we will be watching for that data shortly. So again, my name is Dr. Lisa Kopas. I am here in Houston. My phone number is 713-255-4000. If you are a patient and want to make an appointment, we have appointments for you, and we do all of these procedures. If you are a physician of any kind, but especially my pulmonology colleagues, and you want to get in touch with me, you can email me at the email address that I will put in the show notes. Also, our website is www.houstonlungdocs.com. Come on over and visit us anytime.